Hello friends, so you would have heard by now the two protocols, the general COVID protocol for all the district hospitals, and the second one was the sepsis septic shock. So this is the third one which I would be talking on, ventilation protocol. So friends, as I said, our whole intent in COVID is to avoid patient going on intubation and mechanical ventilation mode, because we understand that the mortality is very high once they get intubated. So the mortality is more than 90% from the two studies that we have found. So it is best to manage them effectively, identify them early, and prevent them from going on ventilator. So if they go on ventilator, so what are the key aspects that we need to keep in mind for managing the ventilated patients? So this protocol was prepared and has been sent to all the district hospitals that we are doing TEDdy rounds. I'm sure you would have had an opportunity to go through this protocol. So this protocol, as you would see, it starts with the intubation. So once you have intubated, so you would have intubated because he would have had worsening of oxygenation. So, and he would have developed ARDS where PaO2 by FiO2 would have been less than 300, and there would have been a respiratory worsening respiratory distress even on NIV, and patient possibly would have been in shock. So these are possible reasons you would have intubated and mechanical. So once you intubate and mechanically ventilated, so the first step you would do is to identify the mode of ventilation. So you could choose either between volume control mode or pressure control mode. So whatever you keep, the key essence of ventilating this ARDS in COVID is low tidal volume. So generally our conventional ventilation used to be with a tidal volume of 10 to 12 ml. So all that philosophy is gone. So right now in COVID, when they come with ARDS, you would maintain ventilation with a tidal volume of 6 to 8 ml per kg body weight, and you would calculate predicted body weight, and this formula also is given in algorithm. For males it's 50 plus 2.3 into height in inches minus 60. For females it is 45.5 plus 2.3 into height minus 60. So you have to measure the height of the patients to calculate the predicted body weight. And now, having intubated, so our assumption is these patients would have severe respiratory failure and are on ARDS. So in ARDS, keeping low tidal volume is one aspect. The second most important aspect is optimizing the PEEP. So we would suggest you would obviously start with a minimum of 5 PEEP, and you could increase it based on the PEEP table that we have provided at the end of algorithm. So if the FiO2 is, say, if you are needing a very high FiO2 of 70 to 80%, there is a different PEEP that we would have indicated, and if it is 50%, so we would have suggested a PEEP based on the table that we have provided. So you follow that, and please try to keep the PEEP optimal, because PEEP is a life saver, and PEEP is the one which really helps in ARDS patients to improve the oxygenation. And you could set the respiratory rate at 14 to 18 per minute, and once you have set the low tidal volume and once you have set the PEEP as per the PEEP table that we would have given, it is important to check the plateau pressure. So I'm sure once this patient is intubated, anesthesiologist or a physician would be managing a ventilator. So plateau pressure is a simple maneuver where you put a end inspiratory hold for less than 10 seconds and you will get a value. So the whole ARDS science revolves around maintaining the plateau pressure less than 30 centimeters of water. And once we have intubated and mechanical ventilated, once you have put him on a controlled mode ventilation with a low total volume, optimal PEEP, and you have checked your plateau pressure, it is important we monitor the serial ABGs to see how the oxygenation is improving. So in ABG, we don't uh, target very high PaO2. So once we have identified that patient is in ARDS and you intubated mechanically ventilated, for us saturation of anywhere around 90%, 90 to 92% is more than good enough. So to maintain that saturation, your PaO2 would be around 55 to anywhere up to 80 is good enough. We don't need a very high oxygenation. So you can maintain the saturation once you have intubated around 90 to 92, even in some cases 88%, as long as all the uh, tissue perfusion is happening well and its compass mental should be good enough. So 90 to 92 is good enough. We don't wish to target 100% saturation when you are dealing with patient with ARDS. So once you have understood the concept of maintaining plateau pressure less than 30, there is another entity called driving pressure. So driving pressure is a simple tool to help prognosticate the patient if this patient is responding to the PEEP you have set and the low tidal volume ventilation uh, to keep the plateau pressure less than 30 is achieved. It helps us to prognosticate and will help us to ascertain if the PEEP what we have set is been optimal. So driving pressure is simply calculated by PEEP plat. So once you check the plateau pressure, if it is say 30 and you have a PEEP, so if the patient's plateau pressure is 30 and if you have set a PEEP of 5, so then it means 30 minus 5 is 25. So that is a high driving pressure. So at this point of time, your intuitive thought should be to increase the PEEP to at least 10 so that you reduce your driving pressure. So obviously this is an algorithmic discussion. I won't go too much into the science of it. So please visit my website www.drpradeeprangappa.com. There is a detailed lecture on ARDS and the whole science of driving pressure. But just remember, when you are tweaking ventilation, there are three arms that are very important. One is you set the low tidal volume. Then the second thing is you put on an optimal PEEP. Then you put on a controlled mode ventilation with an optimal respiratory rate with monitoring of ABG. And these three dimensions we keep alterating to make sure that your plateau pressure is less than 30 and driving pressure is less than 16 centimeter water. And so once you have done all this, so you would measure compliance. So compliance is most of the modern ventilators. I understand most district hospitals have newer ventilators. So the ventilator itself will show what is the compliance that the patient would have, or you can calculate compliance by tidal volume in ml divided by P plat minus PEEP. So that also will give you. So you can calculate physically, but all the ventilators I understand are all new in district hospitals, so they would indicate the compliance for these patients. So once you have put them on that, then it's not the end of the job or end of the tasks that we have. So we need to keep monitoring the plateau pressure. Suppose you put on 6 ml per kg of predicted body weight and you see the plateau pressure is 35, then the next step, logical step would be to reduce the tidal volume up to 4 ml per kg. So you can go down on the tidal volume. Our whole intent and effort to go down on the tidal volume is to keep the plateau pressure less than 30. So we go down on the tidal volume. Once we go down on tidal volume, CO2 builds up. So to compensate, we need to increase the respiratory rate. So we could increase the respiratory rate up to 35 as you keep coming down on tidal volume, and you have to keep optimizing the PEEP as per the PEEP table to make sure. So you have only three targets I would say. The first target is maintain saturation around 90 to 92. The second target is maintain P plat less than 30. The third target, if you are clever, look at the driving pressure, because driving pressure will help you to determine if further PEEP optimization has to be done, and make sure your driving pressure is less than 15 or 16 centimeter water. So these are your targets. So saturation and your plateau pressure, your driving pressure, and for this to achieve, you need to keep tweaking the tidal volumes, respiratory rate, and the mode if needs be. And then you would keep monitoring compliance 4 to 6 hourly. So now, so you have brought down your tidal volume and you have optimized the PEEP, then you have optimized your respiratory rate. Even then, you are not able to achieve good saturation. So that is when you need to reassess the depth of sedation, and you have to optimize the clearance of secretion. So you have to examine his chest, and if you see if there is a lot of secretions, you have to facilitate adequate clearance of secretions. And if there is a wheeze, you have to do good bronchodilation, and you may have to start muscle relaxation. So with either cisatracurium or vecuronium, and keep him completely sedated and paralyzed to achieve better saturation. And this is a stage where you have brought down the tidal volume to 4 ml and you have optimized the PEEP, and you have done good bronchodilation and optimizing the sputum clearance, this is the stage you may have to consider prone ventilation. So this prone ventilation has to be done sooner than later. So the type of ARDS in COVID-19 has found to be, the recent hypothesis suggests there are distinctly two types of ARDS. This is not universally conclusively accepted, but these are the findings that has come from this popular author Gattinoni from Italian group. There is a L-type ARDS and H-type ARDS. What is L-type? L-type ARDS, any ARDS conventionally, as we understand, has low compliance, but in L-type ARDS there is a high compliance and there is a low elastance. And here the recommendation is you keep normal tidal volume. 6 to 8 means you don't go to 4 ml, you keep around 6 to 8 ml per kg, and you could keep PEEP of 8. And there is another one, H type, which is a conventional ARDS where all intensivists or all the anesthesiologists and physicians would be aware, where there is low compliance and high elastance, where you follow the protocol that I have said, reduce the tidal volume, increase the PEEP, and follow the ARDS-NET protocol. In NL type, they found that the weight of the lungs is low, which means the lungs are not flooded with exudatory infiltrates to increase the weight, it is low. And the H type, which is a conventional ARDS where alveoli are flooded with inflammatory exudates, so you have a heavy lungs, which is more than 1.5 kg. In the L type, where compliance is normal, there is no recruitable, because there is no flooding of alveoli, there is no recruitable lungs. So here, the conventional ARDS, which is the H type, has recruitable lungs because the alveoli are flooded with inflammatory exudates. So the physiological, pathophysiological hypothesis of L type is, the authors have reference that there is a ventilation perfusion mismatch in the L type, where there is a lack of hypoxic vasoconstriction, pulmonary vasoconstriction, and there is a ventilatory perfusion mismatch. And because of ventilation perfusion mismatch, there is a huge tachypnea which generates negative intrathoracic pressure. When there is a tachypnea with increased generation of negative intrathoracic pressure, there is a increased tidal volume in these patients. That's why the suggestion is that low tidal volume may not be very helpful in this, and with lung permeability leads to something called patient driven self-inflicted lung injury, and that is what will ultimately lead to the ARDS. So this is the scientific hypothesis in L type, where there is a ventilation perfusion mismatch and there is a lack or absence of hypoxic pulmonary vasoconstriction, and there is a self-driven intrathoracic pressure which increases tidal volume, leading to patient self-inflicted lung injury, which is called PCD. So, and the typical CT chest they have done in L type shows like this, which is peripherally placed ground glass opacities. The H type is our typical ARDS, where you predominantly see basal consolidation with a lot of exudates in the alveoli. But if you see the H type, it is even in the apical, it is more of peripherally placed ground glass opacities. In the H type, the predominant pathophysiological explanation is right to left shunt that typically happens. And there was another paper which subsequently came in Marini, where they showed the L type, where there is ventilation perfusion mismatch and there is absence of pulmonary hypoxic vasoconstriction, where compliance is normal. These are the patients who are at an increased risk of this thrombi formation in the pulmonary vasculature. So that is where there is a hypothesis that we should treat this L type ARDS with anticoagulation, or at least prophylactic enoxaparin or prophylactic dalteparin to prevent this microthrombi formation in the pulmonary capillaries or pulmonary vessels. And L type is the patients who are known to develop this cytokine storm, and all these patients should be on the venous thromboembolism prophylaxis and possibly measures to mitigate this cytokine storm in the form of maybe low dose steroids that you can discuss with experts. So once you have given low tidal volume and you have optimized the PEEP, you have relaxed the patient, optimized bronchodilation, prone ventilation. So when do you prone? Patient is intubated and mechanically ventilated for up to more than 24 hours, and his hypoxemia is not improving. And so recommendation is you prone the patient. Obviously you will discuss with experts how to prone, and proning is recommended for 12 to 16 hours per day, and multiple sessions may be needed. So once you prone for 16 hours, you have to supine again for another 8 to 10 hours, and then you have to reprone. So generally the studies have shown 3 to 4 sessions of proning may be needed to ascertain whether there is a good improvement or good response to the proning that happens. And the indication for proning generally accepted is where your PF ratio is less than 150 and your FiO2 need is more than 60% and you have gone to more than PEEP of maybe 5 or 8 or 10 and your tidal volume, you are maintaining low tidal volume ventilation. So despite prone ventilation, if patient continues to remain hypoxemic, despite prone, despite muscle relaxation, despite protective lung ventilation. When we say protective lung ventilation, it is low tidal volume plus optimal PEEP. With all these measures, then you may have to consider in an extreme case, ECMO is the only life-saving measure. So this is the algorithm that we have given to all the district hospitals, and the easiest for you I would suggest is to just follow this PEEP table. So if you have a patient who is going to FiO2 of 60%, minimum PEEP you would expect is 10. You can discuss with experts and see if you can go beyond 10, because this is a low PEEP table that we have provided you. There is something called high PEEP table, so which experts will help you. Like in our unit, we may have patient with 60% and PEEP of 14. So that has to be individualized case to case, looking at all the other hemodynamic indices. So this is a simple PEEP table. It's a low PEEP table. Like if you have a patient on 100%, then the PEEP that you can go up to is 18 to 24. So that's the degree of PEEP that we can go up to. Um, and in all these ARDS patient, there are other ancillary things. So they need to be on some antibiotics guided by the local protocols or discussing with experts. So once patient is in ARDS and L type or H type and you have adopted all this, discuss with your expert tele team and see if there is a role of methylprednisolone to mitigate the cytokine storm. So methylprednisolone, generally in ARDS, we give it at a dose of 1 mg per kg as an infusion over 24 hours, and we have put in the algorithm, discuss with subject expert, and you have to take all measures to reduce the ventilatory complications like risk of ventilator associated pneumonia. And all this fast track applies to all these critically unwell patients. So even they are intubated, ventilated and prone, don't keep them NPO. We continue feeding even in prone patients, and they need to be optimally sedated. Don't keep them awake, and if needs be relaxed. And all these patients have to be on thromboprophylaxis, and when they are not prone, they have to be in a head end elevation, and please maintain blood glucose level less than 180. So thank you very much. I end with talk with this cartoon which came recently. So relaxation is given only by the government, but Corona hasn't given us relaxation. Please be careful and don't move around unnecessarily in the markets. Thank you very much. So you can rehear to this lecture by visiting the website to gain more clarity and insight if needs be, and you can call me if you need any other help. Thank you all.